I'm Linda Keel, President of Lupus Ontario, and I'd like to welcome you to tonight's webinar on lupus and pregnancy. This is a topic that I know we as an organization haven't put a lot of attention on, but it's a really important topic because so many women are diagnosed with lupus in their childbearing years. And there's a lot of questions around becoming pregnant with lupus. Back in the day when I was diagnosed, it was certainly not highly recommended to proceed with pregnancy, but luckily that doesn't seem to be the case anymore. I know a lot of people with lupus who have delivered healthy babies with better management, preparation for the pregnancy, and there's a lot of exciting research going on in this area. So I'm sure everyone is going to enjoy tonight's presentation. Before we move to the presentation, I just want to remind you of one other thing. On October 22nd, we're having a symposium, a lupus symposium. It's virtual and it runs from 10 to 2, and I hope everyone will be able to attend. It has a lot of information, general research updates. So I just wanted to remind you about that event. But not intending to take away from tonight, which I think is a very, very important topic. So with that, I'm going to hand it back to Joy Phillips to introduce our guest speaker this evening. So enjoy the session.
Thanks, Linda. Good evening, everyone. My name is Joy. I'm a volunteer with Lupus Ontario, and I'm excited to introduce our guest. So Micheline Piquette Miller is a professor and associate dean of research at the Leslie Dan Faculty of Pharmacy at the University of Toronto. Dr. Piquette Miller completed a Bachelor's of Science in Pharmacy and PhD in Pharmacokinetics at the University of Alberta and a postdoctoral fellowship at the University of California in San Francisco. Her research focuses on examining the impact of disease on processes of drug transport and clearance, and how this affects drug safety, with a particular focus in the area of women and children's health. She has published over 130 research articles and has been the recipient of numerous prestigious national and international research awards. She has previously served on the executive councils of the American Society of Clinical Pharmacology and Therapeutics, the Canadian Society of Pharmacology and Therapeutics, and the Canadian Society of Pharmaceutical Sciences, and is a former associate editor of Clinical Pharmacology and Therapeutics. Thank you, everyone, and welcome, or join me in welcoming Dr. Micheline Piquette Miller.
Thank you, Joy, and thank you, Linda. I'm really happy to see all of you guys here tonight, and I'm really excited about speaking to all of you because this is my research. This is what I do, and it's I get excited about it, and I want to be able to share it with people that are actually affected with lupus, because I'm usually just talking to a bunch of other researchers or graduate students, and they don't understand the disease, or they, and you guys truly do, and you truly, I'm going to welcome your questions afterwards, because I find that, this is, it really is important for me to get hands-on experience with you in order to be able to change my research, or to make some modifications in my research to answer really the questions that you guys truly want answered. So with that, I'm just going to share, I'm going to pull up my screen here, and let's see if I can see it. Okay, so do you guys see that? Okay.
Yes, that's great.
Okay, great. Okay, so today I am going to talk about pregnancy and lupus, and then after that I'm going to discuss some of my research, which has been actually examining the impact of lupus on transporters, and how this could impact therapeutic options and therapeutic choices while pregnant with lupus. So I'm just gonna, it's gonna take me a minute here to figure out my buttons here. Okay. Okay, so obviously you guys are all very much aware of lupus. Lupus is an autoimmune disease. The body's immune system starts to attack itself. This immune disease then causes inflammation and damage to your joints, tendons, and organs. It affects about 1 in every 1,000 Canadians. And as mentioned earlier, it's most common in women of childbearing years. That's when it's generally diagnosed. It's during the times between 15 to 44 years old. And it's about 9 out of 10 times it strikes women as opposed to men. And it occurs in this time. So there's a large number of women that are considering having babies. And as I said before, it was previously thought that women with lupus shouldn't have babies. They should consider never having a baby, and that's changed a lot. So lupus itself is actually caused by a combination of things. It's multifactorial. It is genetic, but it's not just solely genetic. It also requires environmental triggers. Environmental triggers things like stress, sunlight, drugs, chemicals, and all of these are then, these triggers are actually, come up in a person that's susceptible to lupus because of their genetic background. And so there's a combination of this, as well as there's thought that hormones play a role. And this is why the women are at much greater risk of getting lupus as opposed to men. So women with lupus can safely get pregnant. So it's no longer said that you should not get pregnant. It's just a conversation just to have with your physician, your rheumatologist, and talk about when you want to get pregnant, because most will have normal pregnancies and healthy babies. Now, there are a few things that they do recommend before you get pregnant. So, and one thing is that the risks are much greater when the disease is not under control. So generally, they recommend that the disease should be under control or in remission for about 6 months before getting pregnant. And while pregnant, there are still higher risks to certain complications during pregnancies. One of the things is disease flares. And disease flares, there's controversies as to whether pregnancy causes an increase in disease flares or it remains the same risk for disease flares. But regardless, a lot of pregnant women with lupus will get disease flares. And so they may require treatment with medications such as the corticosteroids to minimize the potential harm to the mother and the baby. And there's a higher risk for preeclampsia. Preeclampsia, if you're not aware of it, it's a very rapid increase in your blood pressure. You get proteinuria and a sudden appearance of edema, so swelling, particularly in your hands and your face. Now, lupus occurs in about 2 of every 10 women with lupus. And when you get preeclampsia, it also requires treatment, whether it be pharmacological treatment or delivery of the baby. But now, along with this higher risk of preeclampsia, there's also a higher risk for a number of other conditions such as hypertension, diabetes, kidney problems, urinary tract infections, pregnancy loss, low birth weight, and preterm delivery. And again, the risks are actually higher with active disease. So it's important that the disease is kept stabilized during pregnancy. So generally, most women with lupus that are pregnant actually are generally consult with an obstetrician that's experienced in managing high-risk pregnancies. And there's a large number of high-risk pregnancy units throughout the GTA area. which deal with lupus patients. There's a number of lupus clinics that actually have a number of patients with lupus that are pregnant that belong to these clinics. So one thing is that with lupus and pregnancy is plan when to become pregnant. So as I said, it's important to stabilize the disease before and during pregnancy, because the active disease is associated with a greater risk of the pregnancy complication. So this generally requires staying on medication throughout pregnancy. So it's really unwise to discontinue medication on your own, as it could lead to worsening of lupus. And the problems with the disease, the active disease actually will potentially cause more harm to baby than the medication itself. Generally will stay on medication or try to maintain your stability of the disease throughout pregnancy. You should also review the medication list with your physician while planning pregnancy. Quite often, they will change your medications to those drugs that are considered safe during pregnancy for several months before you get pregnant, to make sure that these drugs actually work and that you can safely become pregnant. So that's, again, to prevent this immune activation of the placenta. Okay, so there's a number of medications that are considered safe during pregnancy, and we have a lot of experience with these drugs. A lot of pregnant women have taken these drugs, and there's a lot of evidence to say that they're safe. So the first drug is hydroxychloroquine, or if hydroxychloroquine is not available, chloroquine is given a replacement. And this is used to prevent flares. And it's recommended that lupus patients stay on and take hydroxychloroquine during pregnancy if possible. So they'll generally, women will already be on hydroxychloroquine before they get pregnant. But if they are not on hydroxychloroquine before pregnancy, the doctor may recommend that they start on hydroxychloroquine before pregnancy to maintain that they actually get stabilized on hydroxychloroquine. Then there's the aspirin and non-steroidal anti-inflammatory agents. Those are called NSAIDs. This includes things such as ibuprofen and naproxen. So moderate doses of your NSAIDs can be used until the end of your second trimester, at the beginning of your third trimester. So you can use it until 28 weeks of gestation, but you need to avoid it in the third trimester, as this can affect the baby's blood flow, as well as it can interfere with labor. So in the third trimester, they generally recommend you take acetaminophen for pain and for any either fevers or anything else that you normally might take ibuprofen and naproxen for. Now, recent evidence has suggested that low-dose aspirin may help to prevent or delay the development of preeclampsia. So low-dose aspirin, and this is usually a baby aspirin, which is about 81 milligrams, or some kind of combination of low-dose aspirin that ranges from 60 to 100 milligrams per day. They recommend you start in the first trimester to prevent or delay the development of preeclampsia, and this is taken throughout pregnancy, and it's safe to take right up until labor. Then there's the glucocorticoid steroids. This includes things such as prednisolone or prednisolone. And this is used to prevent or treat flares. And what they recommend is that this should be used at the lowest dose possible. So women are maintained on these drugs, and they actually found that these are safe drugs, but to stay at the low dose, because the high dose glucocorticosteroids could be associated with some negative risks, negative outcomes. There's a higher incidence of diabetes and hypertension with high dose glucocorticosteroids. Then there's a number of immunosuppressants, and a lot of pregnant women will be removed off of these immunosuppressants. But some women may have severe disease that's unresponsive to other treatments, so the physicians may choose to maintain them on these. And these are things such as azathioprine, cyclosporin, and tacrolimus. And overall, the evidence is that these are quite safe in pregnancy, but they have to be cautious and monitor for things such as changes in blood pressure and drug levels in the systemic circulation. And they may actually require the mother to go off of it for the last couple of weeks of pregnancy, just so that it's out of the baby's system before delivery. Heparin is a blood thinner, and it's considered safe during pregnancy. But again, you should be stopping it prior to delivery, because being on heparin increases your risk of bleeding. And so they'll often stop it prior to delivery to decrease this risk of bleeding. So the number of medications to avoid during pregnancy. And so often women will be taken off of it for several months before becoming pregnant in order to minimize any potential harm to the baby. And this includes things like cyclophosphamide, methotrexate, mycophenolate. There's a few different salts of mycophenolate, but Cellcept and Myfortic are both brand name drugs of these mycophenolate products. There's glufonamide, also is not recommended. And then of course there's thalidomide and its derivative lenalidomide, which is known as the brand name of Revlimid. And then warfarin should also be avoided during pregnancy. Generally, women that require a blood thinner, such as warfarin, are then changed over to heparin, because it's considered a much safer drug during pregnancy. So when you are pregnant, the placenta actually plays a critical role in fetal development and protection. And that's what I study. I study the placenta, and I study its function and its involvement in the protection of the fetus, as well as in the delivery of nutrients. So the placenta connects to the fetus via the umbilical cord. So this separates the fetal bloodstream from the maternal bloodstream. So it's actually a membrane that is protective in between these two bloodstreams. So one thing is that the placenta therefore delivers or supplies the nutrients and oxygen from the maternal circulation to the fetus, and it also is able to produce hormones that are necessary for both mother and baby. And in addition to supplying nutrients, it actually is a protective barrier. So it prevents the entry of potentially harmful compounds from the baby. And it also removes a number of waste from the fetus. So the fetus is actually producing things like urine, and it needs to get rid of urea and creatinine. And the placenta therefore then pumps out or removes this from the fetal circulation and deposits into the maternal circulation. So one of the things is, in order to do this effectively, these compounds don't really transfer across this protective membrane. This is a very protective membrane. And so there's a number of transport proteins that are found both facing the maternal blood circulation and facing the fetal blood circulation. So in concert, there's transport proteins that are involved in the transfer of nutrients and hormones and drugs across the placenta from the maternal circulation into the fetal circulation, and vice versa. So some of these transporters are mostly involved in pumping and in removing from the fetal circulation. Others are involved more in uptaking compounds from the maternal blood circulation and then transferring into the fetal blood. And so in some cases, these are bidirectional as well too. So you can actually have them working in both ways, depending on the compound that they are transporting. So they're both involved in the transfer from maternal to fetal, and then the removal from fetal to maternal. So overall, transporters that are found inside the placenta control the amount of nutrients and as well as the chemicals that get to baby. Now, in context of some of my research, some of these proteins prevent the transport of drugs into the fetal compartment, therefore decreasing fetal exposure. There's transporters such as this P-glycoprotein, or I've got it as PGP. And as a drug, substrate drug gets into the placenta, it's responsible for grabbing it and pumping it right back into maternal circulation, therefore preventing its entry into the fetal blood. And these are quite efficient. It will pump these almost as fast as it diffuses into the placenta, and they pump drugs out that women that have lupus are on. So glycoprotein is involved in transporting steroids such as prednisone out of the placenta back into the maternal circulation, as well as hydroxychloroquine. And so what you see is that for these substrates, for these transporters, is that very little gets actually into the fetal blood. It actually, a lot of it, so you'll get a very small proportion of the compound gets into the fetal blood. And so it does serve this very protective mechanism. It's also another very important drug removal influx transporters, which we're just going to call CRP. And I'm just mentioning this because I'll be bringing up these two transporters again in my next couple of slides. Okay, research in my laboratory over the last 10 years, maybe even 15 years, has shown that inflammation and pregnancy complications can cause a dysregulation in the expression of these transporters in the placenta. So these diseases can alter the amount, the amounts of these transporters that are found in the placenta. And so it can either cause increases in some transporters, or it can cause decreases in other transporters. And so overall, this can cause changes in the amount that the fetus is exposed to for these substrates of these transporters. And this we have actually done studies and shown that there is, a reduction in the amount of transporters is associated with the changes in the maternal fetal transfer of compounds, including drugs, a number of drugs. So in preeclampsia, we have seen that there's a decreased transporter levels in placenta of women with preeclampsia for a number of transporters, including this efflux transporters, PCRP, and then a number of other transporters that are considered uptake transporters, or they're equilibrative transporters in which they can be bidirectional transfer. So there's a number of changes here. The overall impact is still, we're still doing studies trying to determine how this affects the fetal exposure to compounds that women with preeclampsia that they take normally for preeclampsia. And so we're in the process of running a number of studies in preeclampsia. We've also found that there's a decrease in transporter levels in placenta of women that have bacterial infections, such as chorioamnionitis. And we get a decrease in some of these protective efflux transporters. And so in some models that we've done, preclinical models, we found that these changes that we saw in human placenta were also happened in other models, and that this was associated with an increase of drugs that it's transferred into the fetal compartment. And then there's also this OATP1, which is both a drug and a hormone transporter. So some of these are not just drug transfers, some of them are also hormone, or they transport things that are naturally found in the maternal and fetal circulation. So we started thinking about, what about autoimmune diseases such as lupus? A lot of the studies that we've done all had conditions that had an inflammation type of component or an inflammatory component. So we hypothesized that autoimmune diseases such as lupus would actually cause a dysregulation of the transporters and could cause changes in the amount of drug that would be prevented from getting to the fetal exposure. So we'd cause changes in the fetal exposure to some of the drugs that these women were on. So overall, our research questions that we've had, and these studies are ongoing. We've actually just started them within less than a year ago, so we're still in the early stages. The first question was, are transporters altered in the placenta of women with lupus? Second question is, do inflammatory flares, such as disease flares that you see with lupus, do they cause changes? And how do changes in transporters affect the transfer of drugs across the placenta? So with regards to the first question, our research is first of all looked at, are transporters altered in the placenta of women with lupus? So we ran this through a number of centers. We were collecting samples from the biobank in Mount Sinai, as well as we were recruiting patients at St. Michael's Hospital and at Sunnybrook Hospitals. And so we recruited patients from their high-risk OB-GYN units, and we obtained informed consent. And then we would actually go and wait at the hospital while they gave delivery and collect their placentas. And again, I have to say this is after delivery, so this is normally the placenta is discarded, and so we would hang out in the back of the hospital and get the placentas from women that had given us informed consent to be able to collect their placenta. So we would take the samples and then rapidly freeze them, and we'd store them at -80 degrees Celsius until analysis. So then we would extract from these human placentas, and we were able to date, we were able to get 30 healthy placentas and about 16 from lupus patients. And this is the samples that we collected to date. We were doing pretty good at getting the samples, but then with the COVID hitting in 2020, we just pretty much stopped our ability to collect these placentas. Okay, so we'd isolate RNA and measure the RNA levels of the transporters, or we'd isolate the protein and then we'd measure the protein levels of these transporters. So based on our initial results from this, the sample size of about 16 patients, we did see that there was a decrease in transporter levels in the placentas from women with lupus. And so you could see here, there was actually quite a pronounced decrease in the levels of P glycoprotein. This an efflux pump. We had a decrease inside this other efflux pump in the BCRP. In another drug transporters, which is OCT3, we saw some trends to decrease. It didn't quite reach significance. Now, one of the things is that these results are not yet conclusive, as we were only able to get a total of 16 placenta from women with lupus before the COVID-19 shut down our clinical study. So we are still trying to get a larger number of samples. And some of these are grouped together. Some of these were delivered a few weeks before term, and some were delivered at term. Normally, we would separate these out. Also, there's a large number of different drugs that the women were on. So we would generally separate out and do the subgroup analysis of these patients. So I figured that we probably need about at least 60 to 80 placentas from women with lupus in order to get a proper sample size. This showed us, even with the small sample sizes, that we had pretty pronounced significant results, which indicates that there are some changes that are being seen. So our next question is, what is the impact of active disease, or these flares, on transporter levels in the placenta? And so flares are often associated with dramatically increased production of several inflammatory proteins, which are called cytokines, and these are involved with tissue inflammation and organ damage. So some of the major inflammatory cytokines that are seen in lupus patients are the interleukins, such as interleukin 6, interleukin 8, interleukin 17, 21, 22. There's a few more as well too. There's tumor necrosis factor, we call them TNF, as well as the interferons. It has been shown that inflammatory cytokines can alter production of transporters in other tissues, that very little is known so far about what happens within placenta. And so we wanted to know what happens with these cytokines. How do these cytokines influence transporters levels and the production? So we ran these placental explant studies. So we actually get this fresh placental tissue, which we can isolate after delivery from healthy volunteers. And they're dissected into small, little, tiny pieces over here. And then they're plated in a culture dish, in which we actually can have them either, untreated control, where they just get media, or they get a cytokine that's dissolved inside the media. So we can look at a number of different cytokines in this, and we can look at this in a number of different placentas from different women, and we can do this also in duplicate. And we incubate this in a tissue culture hood for 24 to 48 hours. Then we collect it, and we collect the tissues, and again we isolate RNA and or the protein, and we analyze it for transporter levels. And so in this case, what we have is that the tissue from the same woman is compared. And so let's say with the tumor necrosis factor treatment, if we have this untreated control, and if you can see this with the line, this is the exact same placenta from the same woman, and those that are treated with tumor necrosis factor. And so we actually have them all paired. There's a few, there are kind of outliers. The majority, we saw though there was a decrease in levels of this P glycoprotein in the treated explants. And we saw also a decrease in levels of this OCT3 transporters in the treated explants, and some. On the other hand, we started seeing a trend of increases with another transporters, BCRP, although this didn't reach significance because we had in some placentas, we had a decrease when we treated the explants. In other cases, we got an increase in levels when we treated with the explants with tumor necrosis factor. So this was quite interesting because this is something that tumor necrosis factor levels can be dramatically elevated in active disease. It's been reported that tumor necrosis factor levels are up to 15 times higher in active lupus as compared to healthy controls. So those that do not have disease as compared to active disease. We looked at interleukin 8, and interleukin 8 levels are actually 20 times higher in active lupus as compared to healthy controls. And so it's very much associated with active disease or lupus flares. And again, we saw that when we treated our explant with interleukin 8, we saw this significant decreases in levels of the P glycoprotein. We saw some changes, a trend, or it looks like a significant decreases in OCT3 with these treatments. Although we still need to analyze a few more samples. So we have just a smaller sample size. And with BCRP, we actually saw there was a strong trend to increase, but this didn't quite reach significance. And so again, we need some additional samples and to do a little bit more research on this. The interleukin 6 levels are higher in active lupus as compared to healthy controls, but they're only about 3 times higher. So not as dramatic changes as you see with tumor necrosis factor interleukin 8, but there is a pronounced increase. But in general, what we found is that there was no significant effect of interleukin 6 on P-glycoprotein. There was no significant effect on OCT3, and there was a trend of decreased expression for the BCRP efflux transporters, but this didn't reach significance yet. So with this information in mind and this research in mind, we have a few different future directions, things that we're working on over the next year to 2 years, in addition to trying to recruit more patients into our studies and trying to get more samples. So as I say, what we want to know is the impact of drug transport changes on maternal to fetal transfer of drugs across the placenta. I have a PhD student that's looking at this particularly, and they're going to perform drug transport and drug disposition studies using appropriate preclinical models in order to evaluate how changes in these drug transporters potentially affect fetal exposure to clinically important drugs. And I think that, 2 of the drugs we'll look at, first of all, are hydroxychloroquine, as well as the glucocorticosteroids. We're also going to do a global proteome assessment. So right now we've just been looking at specific transporters, but could be changes in numerous proteins. So we will be running, using the samples that we have in hand from lupus patients, we are going to perform a global assessment of the placental proteome in women with lupus. And this will help us to characterize the overall physiological changes to placenta. We'll see a whole host of different proteins that are affected, not just the drug transporters, which we looked at, but a number of other transporters and other proteins that are involved in placental health and in nutrient delivery and health of the baby. So in summary, the initial analysis of placenta obtained from women with lupus identified changes in the amount of drug transporters in placenta. So this could affect the amount and type of drugs that babies are exposed to. And it could assist us with making therapeutic decisions for our patients and for lupus patients. So there is a need right now to further examine a larger population of pregnant women with lupus to validate these findings, as well as to look at the potential impact of these changes. So our studies in isolated placental tissues indicate that inflammatory proteins in disease flares could be responsible for these changes, and it further demonstrates the importance of stabilizing the disease during pregnancy. And further research will be important in determining the impact of these drug transporter changes on the maternal to fetal transfer of medication that's commonly used in lupus patients. So I'd like to thank the people in my laboratory, all the graduates. I've got a number of PhD and master's students. Those that contributed to the research that I presented are Angela, Brashi, Camellia, Navaz, Dea, and others that are currently working on these projects in a different aspect are Waing and Mario. Oh, and Dennis Lee is a technician that's working with both myself and Dr. Nevo at Sunnybrook Hospital. So I'd like to thank my collaborators, Dr. Nevo and Dr. Berger. They're at Sunnybrook Hospital and St. Michael's Hospital. They're our heads of the high-risk obstetrician units at these hospitals. I'd also like to thank the Research Center for Women's Health in Infants' Health at Mount Sinai. They're the ones that run the biobank. And it was very critical that I get the samples from the biobank, because this really saved us when COVID-19 came. And Dr. Prasad at Washington State University is helping us with some of the proteomic work. And I'd also really like to thank all of the women who donated their placentas to be used in the study. Very, very much appreciate the people that get involved in research studies such as this. And with that, I would like to to answer questions.
Thank you so much, Dr. Piquette Miller. The research you're doing is so important, and it's so interesting, the results that you're finding. So we really look forward to following up perhaps in a bit of time and seeing what other results you get from your studies. Yeah. So we're going to move into a question and answer period. So participants, please feel free to just click the Q&A icon and type in any questions that you have for Dr. Piquette Miller.
There's one question, Joy. So, Dr. Piquette Miller, in your research, have you found patients who have a dormant case of lupus, and so never experienced any symptoms of lupus, experience flares or symptoms during pregnancy?
I'm getting the placentas after they've been diagnosed with lupus. So in general, most of the patients that I have are it's very well established lupus. We are being, we are going through recruitment efforts, and there's usually the obstetricians are referring the patients to us, and we may have different levels of within the samples that we get. We might have different, extremities of the disease, and so there may be several of these patients may be, in remission when we collect the placentas, but there's other patients that have had some flare-ups during pregnancy. But yes, I'm assuming that this is more of a diagnosis question than a research question. Do you want to elaborate on that person that's asked the question?
It's an anonymous attendee.
Okay.
So I guess they're probably asking if the pregnancy could trigger the flare to a person who has a dormant case of lupus.
Well, that's where this has become, it's quite controversial. There's been some studies that say that pregnancy causes the lupus flares. And they think that in those studies, they say that it's the changes in hormones that actually, set off a lupus flares. And then there's been larger scale studies that have not found a lupus incident of flares. So it's not clear. I've looked at the studies, and both of these, they both make good points. And so I think they need to continue looking at this, and because there's subgroups. So when they saw the increase in flares, there was a certain population of patients that were looked at. And then in the second study, it was a different population of patients with different ethnicities and different care that they didn't see the flares. And so I would think that patients that are well managed on a medication, that they can prevent flares. But when you do some of these studies, you're going to run into patients that are not properly managed on medication.
I can read the next question. Actually, I might combine those two questions from Madeleine Crystal. She has two questions. Are all pregnant people with lupus considered high risk? And is there a specific hospital or OBGYN you recommend in Toronto GTA area for pregnant people with lupus?
Well, the large hospitals all have high risk OB-GYN types of units. So the obstetric units, they have the high risk. And so they do see that the lupus patients, I think the largest is the Toronto General Hospital within the GTA, but I know that Mount Sinai sees a lot of these patients with lupus, and so does Sunnybrook, and so does St. Michael's. That's the ones that I'm familiar with. So I think that all of them are very good. They manage the patients very well. They have the They have the expertise. And are all pregnant women with lupus considered high risk? They basically want a consultation, and that you should be consulting with the obstetrician that's within the high risk units, and you should be consulting with the rheumatologist. So you may not end up being high risk, but there's a potential for high risk. So they do want you to have this consultation. There's an increased amount of monitoring during pregnancy in patients that have lupus. So you're going to have more blood tests and more monitoring, more urine tests, more probably, ultrasounds than other non-lupus patients.
Thank you.
Yeah.
So what is the effect, Alia is asking, what is the effect on tacrolimus or azathioprine on the transport proteins in the placenta? And what levels of lupus markers are considered too high for pregnancy?
Yeah, so both tacrolimus and azathioprine are transported by active transporters. I don't know whether they can actually cause changes to the transport proteins themselves, but I know that they are subject to being transported by transporters in the placenta. Different ones. Tacrolimus is actually the one that I talked about, P-glycoprotein. So tacrolimus and cyclosporin will be their entry into the I'm sorry, I had COVID a few weeks ago and I'm still coughing. So both tacrolimus and cyclosporin, the P-glycoprotein prevents entry. So the fetal exposure is minimized. And azathioprine is different transporter. I'm sorry. Take a moment here.
Take your time.
Okay. What levels is considered too high for pregnancy? I think that's really up to your physicians to have that discussion. I haven't seen anything in the literature that said this is the the cutoff point. So is there a specific hospital? Can we do that one? If you looked into the role of anti-RO and anti-LA with pregnancy, you know what? I've actually think it's really, really interesting. And I'm going to be applying, since I've found so far this really interesting results, and I have so many different questions. It's likely that my research will start looking at some of these other things such as anti-RO and anti-LA. So that'll be my next research grant, in which I can actually focus on the lupus. Right now, the research grant I have was actually more focused around preeclampsia. And I started looking at lupus because there's so many women with lupus that get preeclampsia, and now I'm veering off away from your preeclampsia. So there's.
Next question is, what do you consider? Sorry.
Yeah, what would you consider the inactive lupus with regards to the 6 months for pregnancy? Would that be no symptoms at all? I think it's they usually do a number of different drug. They look at your inflammatory cytokines. They look at other markers of inflammation, and I don't know if there'd be no symptoms at all. I think that they feel that it's stabilized, and and that it's or in remission. So you may have still some symptoms, but they may feel that it's stabilized with the medication you're on. The other thing was that interesting is that I'll bring up this point. It's off topic, but it relates to that. Is that a lot of changes in pregnancy somehow mimic, like the natural changes during pregnancy may be mistaken for flare-ups. And so there's, because you'll often get, me having been pregnant a few times, I know that you get the aches and pains, and you get certain changes in that that you might think that it's a flare-up, but so there's some, this is why seeing an obstetrician that's experienced with lupus patients is important, because they may just say, yep, that's pregnant. That's pregnancy. Do these transporters exist elsewhere in the body? If they do, yes, these transporters exist elsewhere in the body. And actually, when we do some of our, we have done studies using models and different tissues, and we find that you can have effects throughout the body. And it may, in terms of what I've been studying, it can affect the drug levels throughout the body. So you can actually have changes in maternal drug levels because of changes that are, let's say, inside the intestine or in the kidney or in the liver. And so you can have differences in maternal exposures to drugs, in addition to having changes in fetal exposure to drugs. And so this is something that we do research, and we use, we use animal models sometimes, because that's the only way we can study this, because we can't exactly get a lupus patient and start pulling out pieces of their liver or intestine. And yes, and in terms of affecting the function of that tissue, there's that's a big question. Yes, it can, depending on what you're thinking is the function of that tissue. Let's say for the liver clears compounds out of the body, and it's there as a detoxification center. And yes, you can actually have diseases such as liver sort of minimize or decrease the ability of the liver to detoxify chemicals. Okay, is there a way we can contact these doctors in hospice? I'm currently pregnant and diagnosed with lupus. I feel a lot comfortable delivering at blood hospital doctors. They're not experienced. I think that you should definitely call and find out. You could probably ask your obstetrician if he can give you a allow you to see the other doctors at the other hospitals. But I think you probably would need a referral, but you could try to contact, I know that there's a lupus clinic at Toronto General Hospital. So you may just want to contact the individuals at the lupus clinic and see what they would recommend on how to see this, but you would require a referral to see the doctors. And I don't know how difficult it is to get a referral, and I would assume this is between you and your physician, with your relationship, if they feel comfortable in referring you to another obstetrician.
So the last question is, because the other attendees may not be able to see these questions, Dr.
Yes.
Piquette Miller, I'll just read it. If I'd like to give my placenta for your research, how can I do that?
Well, I would love that. As I say, I have the ethics approval at Mount Sinai Hospital, Sunnybrook, and St. Michael's. So we can't just go into any hospital and get a tissue. We actually have to go through a large amount of paperwork and ethics approval to be involved. And it generally takes at least 6 months to a year for me to get the ethics approval at a hospital to do these studies. if your gynecologist is at one of the hospitals that I mentioned, I could, I could give you we have handouts for patient handouts and numbers to call in order to enroll in our research study. You could email me. I'm at University of Toronto. I'm easily found on the website at Faculty of Pharmacy, Leslie Dan, Faculty of Pharmacy, University of Toronto. You can send me an email and tell me where you're supposed to be delivering, and I can kind of give you an indication of whether it's possible. I'm likely going to expand out my ethics approval to other centers in order to get more subjects. So I likely will in the next year try to get the ethics approval over at Toronto General Hospital as well too. It's a manpower issue because I need actually to have a person there talking to patients and asking them to volunteer for our research studies. And I'm still a small operation, small research group. Mm-hmm.
Sorry, there's one more question. What about anti-Ro, anti-LA? Are you specifically interested in researching? I'm currently pregnant and positive in both.
Oh, yeah. Mm-hmm. What do you say? One of the things we also did when we were trying to do is we were actually even getting some blood samples from patients that had lupus, and we were treating our healthy placentas with the blood samples so that we could see how this impacted the transporters inside the placenta. So there, I'm whatever you can, even if you just talk to me, I would say, or to find out where you could potentially donate your blood or donate your placenta, and whether or not it's already ethics in play at that center, that would be great. Yes, and I'm not right now the anti-Ro, anti-LA. It's still just a thought because I still don't have any funding for it yet, and so this is the thing about research, is that it's expensive, and we chase after the what's the most critical questions that need to be answered, and how do we get funding in order to answer those questions.
Great. I think, are those all of the questions you're sending? Yeah.
I'd like to ask a question if it's okay, and I couldn't put it in the Q&A for some reason.
Okay. Mm-hmm.
I'm just wondering, your research is fascinating, a really wonderful presentation. Thank you. I know this is out of scope for what you're studying, but would you expect the same sorts of challenges for patients with, say, a rheumatoid arthritis, Sjogren's, other inflammatory arthritis diseases?
Actually, I would. I somehow lost my. I actually have. I actually saw it with the other autoimmune diseases. So when I was also collecting from other autoimmune diseases, and I saw some changes in rheumatoid arthritis, but very, very small sample size, and so I really can't say that if I group all of the different autoimmune diseases together, I see significant changes that are similar to lupus, but I don't know. That's it's best if I separate them out disease by disease.
Yeah, I just wondered because it seems that there's so many similarities with all these diseases. Thank you.
Yes, and I do see it, and it's different. I think I saw the least changes with psoriasis. There's very little changes with psoriasis, but I did see pronounced changes with with rheumatoid arthritis that were quite similar to what I saw with the lupus patients.
Thank you.
Well, I'd
I
like,
actually have a question as well.
Okay.
Oh, sorry, go ahead.
no, I was just going to say, I
Okay.
wanted to thank all of the attendees for your questions. They're really
Oh,
thoughtful. Mhm.
yeah, there's been great questions so far. I actually have a question. Just it made me think of it when we were talking about the anti-Roe and the anti-law, and I was just wondering what sorts of changes in the placenta, if any, are associated with neonatal lupus? Or
Yeah,
yeah.
with the neonatal lupus, I don't think they've noticed any. I don't have that information. I don't think it's been studied.
Yeah.
To tell you the truth, I've pulled out probably every paper imaginable on placenta, lupus, you know, and tried to go through as to what's been done and what hasn't been done. So, and again, that's a very, you start getting really small groups. I think that there was one study in which they took blood samples from pregnant lupus patients, and then after they followed them up, then they actually, looked at see if they could actually detect differences in the bloodstream from women that had the that did have it or didn't, or the babies had it or babies didn't have it, and they tried to identify, whether there was something in the blood that they could use as a biomarker. And they identified a couple of proteins that were somewhat elevated, but I don't think that any of them would have met the standards for a biomarker.
Yeah, thank you. Okay, so if there are no other questions, I think we can wrap up. Thank you so much again, Dr. Piquette Miller. Your research is fascinating and it's so important. It means a lot to a lot of us in the lupus community that someone is investigating such important questions. And yeah, great presentation. So thank you very, very much for taking the time to be here.
Great. Thank you very much. And I look forward to keeping on, discussing with you as I'm doing my research and preparing research applications. And I'd love to get input from your society.
Wonderful.
So thank you for having me here, and thank you all for attending. Okay. Bye.
Bye. Thank you.
Good night.
Bye.
Good night,
Thank
everyone.
you.
Take care, everyone.
Thank you.